Welcome to the Fracture Prevention Central webinar, Patient Identification for Your Fracture Liaison Service. Fracture Prevention Central, brought to you by the National Bone Health Alliance, is made possible through support from Amgen, Inc. and Eli Lilly and Company, Inc. I'll now introduce you to Debbie Zeldow, MBA, Senior Director, Clinical Programs for the National Bone Health Alliance. Please go ahead.
Thank you all for joining us today. We have two fabulous speakers for our webinar on patient identification for your FLS. But I wanted to give you a quick overview of NBHA for those of you who don't know us. The National Bone Health Alliance was launched in 2010 as a public-private partnership that brings together the expertise and resources of its many public, private, and nonprofit partners to provide a platform to address the issues important to bone health. NBHA currently has 55 members that include 35 nonprofit members, 16 private sector members, and 4 government agency liaisons, which provides a collective reach to over 100,000 healthcare professionals and 10 million consumers. NBHA's vision is to improve the overall health and quality of life of all Americans by enhancing their bone health, with a focus on addressing the priorities of the Bone Health Summit National Action Plan to promote bone health and prevent disease, improve diagnosis and treatment, and enhance research, surveillance, and evaluation. Fracture Prevention Central was launched in March of 2013 to help healthcare professionals and administrators implement a coordinator-based post-fracture FLS model of care to reduce secondary fractures and the associated costs while increasing patient outcomes. There are currently over 3,000 registrants to the site. Fracture Prevention Central provides a wealth of free resources, tools, and materials that we continuously add to. All of the materials that are available on the site are ones that you can use and adapt to what you need. And I just wanted to mention that all of the Fracture Prevention Central webinars are also available on demand on the site and on the NBHA YouTube channel. And the webinar today will also be available within a week. I also wanted to quickly mention a new service of NBHA, which is the one-on-one consult service, which could be a great follow-up to this webinar or other questions or concerns that you have in implementing an FLS. Essentially, I'm sorry, my slide's a little messed up there. Essentially, we connect you with an FLS expert based on the needs that you have. You go onto NBHA's website, Fracture Prevention Central. You click on the consult page, and then you complete the online request form. And we look at your questions, so the more information you put in, the better, because we can then connect you with an expert that really has information and resources tied into your specific needs. Great. At this point, I'd like to introduce our two speakers. We have Ann Lake and Karen Vujovic. Ann, can I please turn it over to you?
Absolutely. Hello, everyone. I see some people I recognize, and I see some people I don't, maybe some newcomers. So I'm so glad to see everybody on board today. And I can only assume that if you're on this webinar and you're interested in how to identify the patient, that you already have in your mind the idea of the FLS program, or maybe you have something on the ground. You've started something. There's something going on in your institution. Maybe there's talk around the round table, the C-suite's on board, and you're getting started, or maybe you're in the middle of it and you're just having trouble capturing all those patients. So hopefully this will help fill in some gaps for you today. Just to let you know a little bit about myself, I'm a doctor of nursing practice. I specialize in both family practice and in orthopedics. I run and coordinate the Fracture Liaison Service program here at Wake Forest Baptist Medical Center in Winston-Salem, North Carolina. We are a level 1 trauma center here in the Triad area of North Carolina, and we get patients from at least 4 different states around our area as the trauma center. We don't just see trauma patients, though. Sometimes when I mention a trauma center, people say, oh, well, that won't work for us here because we don't have trauma. It's not about trauma patients. It's about those fragility fracture patients, but those trauma patients patients also need a bone health evaluation as well. So hopefully as we talk about identification in the next little bit of time, you'll see how really this particular program fits into any model or any workflow or any health institution that you may be in. I currently work in an open institution, and my colleague does as well. But if you're in a closed institution or if you're in a smaller facility, maybe a regional hospital, or even a local hospital, this program will work for all of your patients. And the reason that it will work is because it is about quality improvement and improving the value of care for all of our patients that we see, particularly those patients that are 50 and over that have had a fragility fracture. So we'll go ahead and get on into the patient identification portion of this, and I'm going to see if I can work these slides here. All right, that tells you a little bit about me and also my colleague who's going to speak after me. Next slide here. Okay, trouble advancing the slides. Let me see. There we go. All right. So basically, again, just a little bit about the FLS service. The key points of your particular program are that it's got to be care coordinated. It can't just be necessarily housed in one specialty and then you expect to get the patients from the other specialties, because that just won't happen. You have to communicate. Whether you're in a small institution or whether you're in a huge medical center, whether it's research or academic or whatever it may be, you have to have a care coordinated model approach, and it requires multiple providers along that continuum of care. So these providers can help guide the patient through this osteoporosis management in the workflow cycle. You'll hear a little bit more from Karen about what their system looks like, which is somewhat similar to ours. But the key point is it's real simple to identify the patient. The part of identification is not the problem. The part is actually capturing the patient and getting the patient to your FLS provider. So the first two identifiers that you want to consider when you're thinking about how do I identify the patient, what's the right patient? Well, here at Wake Forest, we like to say any patient greater than 49 that's had a fragility fracture. So what is the definition of a fragility fracture? Those low trauma injuries, lifting something very light, you have a fracture, or you have a low trauma injury, fall from standing height. So we all know the definition of that. So those patients that are greater than 49 that have had a fragility fracture. Now, we include other patients because we are a trauma institution and we see a lot of motor vehicle accidents and those kind of things. So we include really any patient over the age of 49 that's had a fracture that we are concerned about compromised bone quality. So think about your system, think about where you want to start, and the two easy ways to start are greater than 49 with a fragility fracture. You probably want to identify the three main fragility fracture sites first, and that would be your wrist, hip, and your spine. But please keep in mind that recently in the last year and a half that the National Bone Health Alliance recommended to CMS that a patient be identified with osteoporosis if they had a low bone density and they not only had a fragility fracture of the wrist, hip, or spine, but they also had a fracture in another area of the body and had multiple risk factors that would compromise their bone quality. So don't be blindsided by just saying, oh, this patient had an ankle fracture, so they don't need to go. No, if they had a low trauma fracture and it was considered a fragility fracture, that patient would be one of those patients you want to identify as well. So the next slide would be, what are the three I's? So the three I's to a successful model is the identification, the investigation, and the initiation. As you all know today, we're talking about the identification part. And I will tell you, I have done multiple lectures, multiple mentorships. People have come to Wake Forest and had site visits with me, and the number one challenge is what we're talking about today. It's getting the patient from point A provider to point B provider to point C provider and putting the ABCs of the FLS program in place to get that patient where they need to go. The first part of your team, you've got that physician champion. Now let's think about where the patient would come into your system. How are you going to get these patients? So if you have an FLS provider that is waiting in the wings for this patient to get to them, say they may be in orthopedics like I am, they may be in internal medicine, they may be in gerontology, they may be in endocrinology, rheumatology, whatever specialty they may be in, whether they're in family practice, whoever that provider is, they're waiting in the wings, okay? But how is that patient going to get to that provider? Well, the patient's going to present to the institution in one of two ways. They may actually come through the ER, so they had a fragility fracture in the ER. How are you going to get the ER staff, how are you going to get the ER nurses, maybe the ER physicians to say, hey, this patient is in our health system, they've had a fragility fracture, and they need to get to our fracture liaison team. They need to get to our coordinator, our provider. They need to get to this person so they can have further investigation and initiation of treatment. Think about your system and think about what the current processes are to get a patient from the ER to a quality program. For instance, if a patient comes in the ER and they're a newly diabetic patient and they need to see a dietitian or a diabetic educator on the outside or maybe even be referred to endocrinology, how does that currently happen? Because that same process is the process that will work for your FLS program. It's a quality program for your fracture patients that have had fragility fractures who are at high risk for fractures, and they need to be seen by a fracture liaison provider. So think about what processes are currently in place and simply adapt those same processes to get that patient from the ER to your FLS provider. Now, what if the patient comes to the ER and is discharged? They have a fracture and they're discharged. Think about where the patient's going to go along the continuum of care and how you can coordinate communication with providers along that process to get the patient to the FLS program. If the patient comes through the ER and they're actually admitted to the hospital, that makes it a teeny bit easier. Why? Because the patient's there for a couple of days. You can think about the team that you have in place. Maybe you have an FLS coordinator or maybe you have a nurse navigator that's on the floor, an orthopedic nurse navigator, and they can say, oh, we got this patient, we know where they need to go, and they can put them into the workflow process. That makes it a little bit easier. But again, ER, discharge, ER admission. How do you get the patient? Once you know that they're there, how do you get them to your FLS provider? Think about your system and think about who are the key people along that communication line that can help with coordination. Some tools that you may have in place, the tools that you may have in place would be things like your EHR system, maybe your social workers, whatever pathway that you currently have for communication are the things that you want to consider as you're thinking about capturing these patients. So, your FLS coordinators, this is sort of a quick review. So most of these FLS coordinators, a lot of us are nurse practitioners. That's what Karen and I are. They may be a PA within a specialty practice, but they need to have skills and abilities to be able to talk to patients and a solid knowledge base of osteoporosis and those skills to develop relationships. They need to work closely with your physician champion. Sometimes they're located in the hospital. Sometimes they're located in an outpatient setting like I am. And sometimes they may actually be located in other departments. So you just have to kind of think, how will the patient, again, get to point A to point B to point C along this continuum of care? But keep it simple. 2 identifiers, 50 and over with a fragility fracture. So one of the things that we do here at Wake, just talking about our processes, when a patient comes into the ER, we're an academic health institution. So we have residents and we have interns, and it's a great place to be, but a lot of times you don't have residents and interns. You just have your basic private physicians that are on staff, or maybe your private orthopedist, or maybe your hospital-employed orthopedist and physicians that are working on board, maybe some of your hospitalists. Think about your team. Think about who the patient's going to see. And then the best way to communicate nowadays is obviously not by paper much anymore, but it's by that meaningful use pathway that we always love, that we all of us love, and that's by the electronic health record, okay? So one of the things that we have built into our electronic health record here at Wake is a unique way to send in and put in a referral. And you can see on this slide where it basically says the patient's been identified. They were identified by the resident or the intern or maybe the nurse in the ER or maybe the physician in the ER. Someone put in the ambulatory referral to the orthopedic osteoporosis clinic. So in your EHR systems, because most of us have those now, and if you don't, simply think about the paper system that you have for your communication system. But whatever system you have in place, you want to try to make this a very quick pull the trigger mechanism where there's an automatic referral put in, just like you would if it was a new diabetic that needed to see the dietitian or the diabetic educator. How would you get that patient to that provider? So if you can set up a way to have an automatic referral, the patient is identified, the automatic referral is placed, then the patient's in the workflow, and then that will help make sure that the patient gets to where they need to go. Part of the identification comes from key providers along this continuum of care recognizing the patient. So it may mean that, I think Karen's going to talk about meeting after meetings and some of the things that you have to do to build team support. And this is going to be very important, so I'm looking forward to hearing her talk about that. Because what you will need to do is, as you're getting things started, if you look at where your current deficiency level is in identification of the patient, you'll need to target that department. If it's in the ER and you're not capturing those patients that are in the ER and discharged, you need to go down and meet with those people in the ER and say, listen, we're missing these patients. Everybody deserves the same quality of care. How are we going to get these patients captured? We need to figure out a way to make sure that these patients get where they need to go. It's easier for the inpatient, but what about these patients that are discharged? So you may need to have some meetings with key leaders, maybe the ER nurse, maybe the ER administrator, and maybe the ER physician, some of your providers that will be in touch with those patients down there. Now, I'm going to probably throw something out there that people might get ruffle their feathers a little bit, but I will throw this out there because I do think it's very important, and it's this. There is no reason in the world that an orthopedic osteoporosis referral or an osteoporosis FLS referral cannot be done by a nurse. Okay? This should be a nurse call. If a physician can't remember to identify the patient, then the nurse can certainly be engaged to remind the physician to put the order in if it has to be originated that way. But nurses can be critical people along this continuum of care of identification of the patient to get that order instituted. Why? Because we are the ones that are on that side of trying to get the quality of care for that patient, and we know what we're going to be held accountable to. So as a nurse or a PA or someone that may not be a physician in this position, identify that patient and go to that physician and say, we need an order here. And be aggressive because it's all about, number one, improving the outcome of your patient and improving the value of care for your patient, but it's also about improving the quality of care that your institution is giving, and we're all going to be held accountable for that as we continue to go forward with what we're trying to do. So as you can see, I left some of these slides up here, and really it talks a little bit about the implementation and some of the external and some of the internal processes. And I wanted this slide to be in here because what will happen is as you get your FLS program going and you start to identify your patients internally, what's going to happen is local people in the area are going to hear about your program. Because even though this is not a new concept to those on the call today, it's a new concept to a lot of people across the country. And what's interesting is people will come in and they'll say, nobody ever told me about my bones. Nobody ever talked to me. This is the only place that I've ever heard that has a program like this. So as you get your program going and you start doing a really great job of identifying patients, the word gets out. So not only externally are you going to have exposure for patients in your area, but more internal communication will occur as well. So through identification of these patients that have had fractures, you will see an evolution of growth of your FLS program to include things like patients that maybe haven't fractured but are at high risk. For instance, maybe some infectious disease patients with HIV that have compromised bone quality because they've been on antiviral medications, and maybe some of your lung patients that have COPD that have been on steroids, and some of your gynecology patients that have been treated but have had bone loss. Where do we send these people? They're going to look to your FLS program. So identification is critical not only for your fragility fracture patients, but also for growth and networking within your system internally and also externally for your community, because it's going to build a quality network. Again, the next slide talks about networking within your health system. These are other key areas where identification of the patient is very, very important. If you have providers that are in other departments like physical medicine and rehab, maybe pain management, maybe your physicians that are doing vertebroplasties or kyphoplasties, maybe your interventional radiologist. These are all departments that, you can reach out to and say, listen, these are the patients we're looking for. Help us recruit these patients to improve the quality of care. Again, rheumatology patients, maybe some of your long-term care facilities that your patients are discharged to from your local acute care facilities. Women's health, there's a lot of factors here. These are all where patients can be identified, okay? So keep that in mind in terms of growth and expectation of your FLS program. We tend to sometimes be narrow-minded when we think about specific population of patients, like these patients 50 and over that have had a fragility fracture, and we say, these are the only patients we're going to see. Well, guess what? There's other patients that have compromised bone quality that would benefit from this service, and it really helps the quality of care for the patients within all of our community setting there. So if you think about it, not only is it identifying these patients that are at high risk because they've had a fracture, but also these patients that may have been missed along the continuum of care that have had fractures in the past. What's the one question that we commonly ask nowadays is, have you had any height loss? Guess what? If the patient says yes, you get an x-ray that had a vertebral fracture, they need to see the fracture liaison specialist. That's an identified patient there. The algorithm of care that we use on the inpatient side, again, here at Wake, we include all patients over the age of 49 who have sustained a fragility fracture. The referral population, as you can see, really has to do with, based on our national quality reporting initiatives, we try to improve our quality of care by looking at the Osteoporosis Foundation guidelines and then looking at some of the measures that are now being identified by CMS. Why? Because we want to make sure we're meeting these measures, and the reason for that is because we're going to be paid on the value of care we're giving. And so if we can prove that we're meeting these measures, we're going to have better reimbursement. So we just target those three things, and those three quality reporting initiatives at this point that have been approved are: the patient has been identified, they're 50 and over with a fragility fracture, they've been appropriately referred to a fracture liaison provider. Number 2, they've had appropriate lab work done. Number 3, they had a bone density. So those are the little things that we look at and we try to incorporate in our program. We use primarily we use education that is provided through handouts and pamphlets. We have direct communication from my nurse and from the other providers within our health system. We use a lot of the EHRs. We have a video that we play for our inpatients before they're discharged, introducing them to the fracture liaison service. I'll tell you this sounds kind of funny, but one of the best ways to identify a patient is giving the patient the information, and they will tell you, I need to go to that person. They will identify themselves a lot of the times, but we've got to give them tools they need to get there. I will do a 2-week follow-up. Once they've seen the orthopedic provider, they will come to me, and they will see me, and I will do a workup on them, and that is part of the investigation part. And then, of course, they will follow up and will initiate therapy. Again, just a reiteration of how we capture our patients on the outpatient side. If the patient's in the emergency department and they're greater than 49, a referral is automatically placed. The nurse will communicate with the resident or the intern if the orthopedic resident is under my watch with Dr. Miller, who's my supervising physician. They know that they better put in that referral. They've been educated at the get-go to put in that referral. Again, that referral is placed automatically, and then, of course, there's usually hopefully within a 2 to 3 week period, depending on the disposition of the patient, we will see the patient back and do the investigation portion. So really, we're talking about about something that sounds relatively simple, but navigating through a large health system can be very challenging. Navigating through a smaller health system can be challenging if you're not sure where the patient's coming and how they can get to you. So think about what you currently have in place. Now, what I want to just reference real quick here, these are the references that I used, but there is a handout that I would strongly recommend that everybody take a look at. If you look on the left-hand side of your screen and you click on handouts, there's an article that we recently got published through the Journal of Bone and Joint Surgery talking about establishing a fracture liaison service. Again, this is the orthopedic approach. It doesn't matter which approach you all take if you have another specialty, and Karen's going to address some of that as she begins her talk in just a second. But this is a great resource article that talks about the identification of the patient, how to get the patient in the workflow, what your framework might look like, and the main point here is this, that this will work from the smallest to the largest institution, as long as someone is able to pull the trigger and get all the parties involved that need to be involved to identify these patients. Thank you so much for the honor of talking to you all today, and I'm going to turn it over to Karen for her presentation, and then we'll be glad to take some question and answers at the end. Thank you to everyone participating today. Karen, I'll turn it over to you.
Thanks, Ann. So our system here is also an open system like Ann's alluded to earlier. Ours is slightly different in that we don't have an orthopedic physician champion. So we've had to develop and become very creative in how we have gotten our FLS started. We were very fortunate. We were one of 3 sites that were selected a couple of years ago by the MBHA to get an FLS system started, and we were using a cloud-based platform at the time to assist us in tracking patients and going through those I's that Ann was relaying earlier about the identification and initiating medication, etc. So once we were selected, then we had to get started. And for us, we faced several challenges, but we managed to be, as I said, pretty creative. We met multiple times with multiple departments. We've met with Department of Orthopedic personnel, general internal medicine, primary care providers, case managers, nursing leadership, trauma chiefs, billing and insurance departments, the IT, and then the electronic health record groups as well. And I should say, I didn't really introduce myself. I am also a family nurse practitioner and have been with the Department of Endocrine for, I guess, about 14 years now. And actually, I am in the Osteoporosis Center at the University of Pittsburgh. So obviously, we're very interested in preventing fractures. One of the challenges we faced, though, is that our department does a lot of research, and that had been my primary focus. I was clinical for many years prior to getting into research, but the last time I was clinical, we were still using paper charts and using pagers. So the first thing we encountered was, what's a pickle phone? Because that's how they were telling us to get in touch with people. And so we had a lot of just initial basic hurdles that if you're already coming from a clinical perspective, you won't face that same level of challenge. Obviously, research handles our patients very different than the clinical side, so again, there was a bit of transition for us. Again, with IT, when I first started with the University of Pittsburgh, we had one IT person for the clinic that I managed and for the School of Nursing. Now there are multiple upon multiple departments of IT, and you really sort of need to know who you are going to call. Some IT issues that we found to be challenges initially were we had university computers on hospital servers and connecting the university DEXA scanner to the hospital server and DEXA reports getting them into Stentor. So again, creative ways to come about that, but we have managed. Electronic health records. In research, we had not moved into electronic health records. We're still using paper. So in order for us to get this program started, we had to learn how to use 2 different electronic health records for both inpatient and outpatient. They use separate ones. So attended multiple classes and lots of phone calls, but I'm getting better now. I got pretty good at the erroneous encounters and addendums. Patient education. Excuse me. We were, again, we really didn't have a physician champion in ortho, so we just sort of attempted to find a way, again, ourselves that would help us to meet the needs of the patients and identify as many patients as possible. And we obviously, as a nurse practitioner, my primary focus has always been on patient education. But where do we begin that? Inpatient versus outpatient, and then also what materials should we use? Do we need institutional approval, or does the logo have to be on it? Do we print it ourselves or have it done professionally? What would we need to do to run an inpatient video? And it's never just one phone call or one email. It's because you're always initially calling the wrong department. But eventually we get that taken care of as well. Finally, once we had those hurdles out of the way, we were able to actually begin seeing patients. Again, two processes here as well. As we did not have a referral system in place, and no one is actually referring patients to us initially, what we were given was proxy access to orthopedic physicians, surgeons, patient lists. So what I do is review that list at least 3 times a week. I try to do it daily, but at least 3 times a week to see what patients would be appropriate for FLS. Now, that only captures inpatients. I don't get any outpatient referrals at this time, and I am the only FLS person that is doing this full-time. The staff we have here always is very eager and willing to pitch in, but it is essentially me. So because we don't have that support group, then I have to just try and just do what I can to the best of my ability. And it also should just give you some encouragement that regardless of what you're starting with, you're still going to be impacting patients, and that's really what the goal is. We had finally met with a couple of individuals that are setting up a referral system in the inpatient chart so that our residents and fellows, once they come across a patient that would be appropriate, will be able to just click a button and I will automatically get notified of that patient. So that's down the road, but we are at least moving in that direction. So once I have comprised a list of those that would be eligible for the FLS, I go off to see them in the hospital and meet with them the first time. I do a little bit of education at that point, but what I have found is when I see them when they're 1 or 2 days post-op, they're still dealing with the effects of the anesthesia and they're on pain medications. So maybe half of them actually remember seeing me when they're in the hospital. There's so many people coming in with white coats, it's hard to make an impression. So I do leave my card and I do follow up with them myself in a couple of weeks to schedule our appointments at that point. I order labs when they're in the hospital, and I've captured multiple patients that were significantly low in vitamin D. So while they're inpatient, I'll get them started on repletion dosing and then follow that up when I meet with them in a few weeks. Once they are discharged then, again, because we don't have any sort of referral system from other departments at this point, I have to track the discharge in the electronic health record, where they're being discharged to, and then find out when their orthopedic appointment will be. We're very fortunate in that our department, our clinic, is actually located 1 floor above the orthopedic clinic, so it makes it very convenient for the patients when they're coming in for their orthopedic follow-up visit. I see them, and I do try to see them also either at their 2-week visit or their 6-week visit. One of the things I found is that if we see them too far outside of the 6-week visit, they sort of lose interest because they're already healing, and there's too many other things that are vying for their attention at that point. Scheduling their appointments is, again, something that I do, so it depends if they're in a skilled nursing facility. I have to work with the patient and the nurse and the transportation coordinators. If they're home, I work with the caregivers to try and, schedule that appointment as well. When I meet them for the first time outside as an outpatient, we see them after their orthopedic visit. Unfortunately, we don't know exactly how long that orthopedic visit is going to take. That can be anywhere from a half hour, 45 minutes to 3 or 4 hours. So depending upon when they get here, I will modify my education for that level of fatigue that they're experiencing or frustration or whatever. So we definitely try to get the DEXA scan done while they are here, and then I review that with them. I review the labs that we had done while they were inpatient. Again, start educating. I have put together a packet that I give them with pretty basic materials, but I think they're pretty impactful. And then I have, my identification on the front of that. So if they're just completely overwhelmed, they can always, contact me afterwards. Okay. My slide doesn't, oh, there we go. Okay. Now, our other option is, as Ann had said, as her facility is as well, ours is a tertiary center, and we get patients from Ohio, the other side of the state of Pennsylvania, West Virginia. So sometimes it's just a hardship for the patients to make it here. So for those patients, I will do a telephone visit, and I have had pretty good success with it. I will send them a script for the DEXA scan, and then we'll review that with them over the phone as well. It's not quite as good as in person, but it still is better than them not receiving anything. I do send an FLS packet if I haven't given them one in the hospital. I try to save those for patients who I think might not be coming back for whatever reason and provide that to them when they're in the hospital at that time. It's a little more labor-intensive because of, the packaging and sending and trying to schedule the telephone call itself, but it still is an option and, again, able to meet the needs of the patient. Then after I'm finished with them, either the outpatient visit over the phone or in person, then I put together a letter for their PCP with our recommendations. If I've started them on the medication already myself, then I just let the physician know. I typically tend to write a script for about 1 year with no refills because I definitely don't want to step in place of their physician, but I do want to fill that gap. And so far I have not had any PCP pushback from anyone who I've started medications on. Also put together a DEXA report and a fracture report for that physician as well. If for some reason the patients are adamant that they do not want to start until they talk with their PCP, I am completely on board with that as well, but then I do have to follow up with them to see if we've got that started. Sometimes they are waiting for their physicians to call them, and unfortunately we know that doesn't happen in primary care. It's just so busy that that gets pushed to the end of the pile. So I do a lot of patient advocacy encouragement so that they would be their best patient advocates. And again, a couple of phone calls, but it does seem to get the job done eventually. Ongoing follow-up after that visit as an outpatient, I have put together a tickler file for just myself so that I can try and make sure I don't drop any patients, like who could be seen at 2 weeks versus 6 weeks. I have a file for those I'm still waiting on their DEXA scans and lab results if they're getting done remotely. I'm looking to see if they have been started on PCP or the PCP has started them on medications. Because we have a lot of patients here that are outside of our insurance network, I can't always pull up that information in our electronic health record. So, again, it requires follow-up phone calls. If they were started on the meds, I try to determine how they're doing, any adverse effects. Also, if they are, then I will discuss alternative medications we might want to try. And then I'm also looking to see if there's any subsequent fractures just in follow-up. Basically, that is how we're doing it here. Again, it's different, and again, it's had to be very adaptive just because we have not had the level of support we would like to. But hopefully down the road, we are making strides, and we're very impressed with what we're doing. It is just much slower than I would like, of course, but we are getting there. So basically, that's it for here. Debbie, I guess I'll turn it over to you, and then if we have any questions, we can go from there.
Great. Thank you. Right now we're going to leave some time so we can have some questions. So I will ask Tammy if she could give instructions to everyone on the line as to how to get their questions out there so we can have them answered.
Certainly. Thank you. Ladies and gentlemen, to ask a question via the web presentation, select the chat pod located in the lower left corner of your screen, then type and send your question. If you wish to ask a question live via the phone, press star 1 on your telephone keypad. I will announce each caller prior to bringing you into conference, and please remember if you have your phone on mute to take it off of mute when you are selected to ask your question. Once again, to ask a question via the web presentation, select the chat pod located in the lower left corner of your screen, then type and send your question. To ask a question live, press star 1 on your telephone keypad.
I think there was one question about slides today. Do they have a way of getting the slides, Debbie?
Yes. The presentation will be available on Fracture Prevention Central as well as the YouTube channel within a week, and we'll send out an alert about that.
Can they get the slides, though? That's what they were asking.
Yeah, we're happy to send on the slides to people who want them. They are downloadable also on the Fracture Prevention Central website when we post that as well.
Perfect. Okay. Yeah, so I think we answered some of those.
There was a question there about, are you able to bill for telephone visits? And my understanding is that yes, you can. I, however, am not. Right now, I am actually not billing for any of my services. Right now, I'm working actually on a grant, and so the only thing we are billing for is the DEXA scan that we do. So once we do have established the FLS, then we'll be able to begin billing for services.
Let me address that also. There is a way to bill for telephone visits, and it actually was a new code that came out this past year, and it had to do with chronic disease management, and it's a special code, and actually that was on the NBHA website. But it is chronic disease management, and it's got several lists of different diseases in there, and osteoporosis is one of them. But there is a certain requirement to using that code. It's like a 20-minute call, and then you get a certain payment for each patient that you have. So it really sort of was more on a care coordinated type coding process. Currently, in everyday practice situation, if I call a patient to talk with them, I cannot bill for a telephone call visit. It's not like a regular CPT, but there is a CPT code that can be used for a telephone call, but it has to do with chronic disease management, and that is actually on the National Bone Health Alliance website if anybody was interested in finding out that code, especially if it's a nurse navigator that has a lot of patients that they're managing with another provider. That might actually be something that might be beneficial for that provider. But for me, I cannot bill for telephone visits as a general rule.
Yeah, and this is David Lee. Just a little bit to add to that, and we'll be sure in the resources to put some links out to some of the CMS resources. So this is called the Chronic Care Management Code, which kicked in this year, which allows for folks, if you're doing 20 minutes of even telephonic care coordination per month on patients with 2 or more chronic diseases, you can get about $40 per member per month. But as Ann said, there are some challenges in terms of you have to get a copay from the patient, you have to get their consent. But one of the things that we're really looking at, because it's a new potential source of revenue, especially for the coordinator role, is to see how we can wrap this into the FLS, and are looking to actually do a future webinar that will include some more details about that. So yeah, we'll have some resources once we put up the slides and other things that we can point you to, because it's a really important new opportunity. Thanks.
Perfect. There's a question about treating osteopenia, so let me address that one real quick. Osteopenia is a general rule. If a patient is osteopenic and they have a low fracture score, their frax is low, then if they come in and they have not had a fracture, but they have osteopenia and you're just getting that bone density, with a low frax, you wouldn't actively treat that patient. If a patient has osteopenia and they've had a fragility fracture, you need to consider osteoporosis from that standpoint. And the reason you need to consider osteoporosis is because the patient had a fragility fracture, so you're not worried about the bone density. You need to be worried about the bone quality. And so at that point, the patient needs treatment to improve their bone quality. So if a patient comes to see you, they've had a fragility fracture, and the bone density shows osteopenia, you still need to treat that patient. But if they haven't had a fracture, a fragility fracture, and they have a low FRAX score, then you don't need to treat that patient. You would monitor. Now, the other patient would be a patient that comes to you with osteopenia, but they have a high FRAX score, and if they have osteopenia with a high FRAX, then you would absolutely treat. So I hope that answers the question about the osteopenia. Karen, do you want to address the question about the EHR? I can address that one as well, but would you like to address that one?
Sure. I was just going to say, on the osteopenia question, we actually had a patient that I saw this morning that had a hip fracture, and her DEXA, which we really just got to establish a baseline, ended up showing just osteopenia. So, this was a ground level fall hip fracture, which by diagnosis is osteoporosis. And so it doesn't always line up what you see on the DEXA with what you're seeing clinically. So as Ann said, this would obviously be a patient that would require treatment. The electronic health record, absolutely, that's actually what I'm using to identify patients. But not so much based on ICD-10 codes at this point or procedure codes, but rather just based on the surgeons that they're assigned to, and then I have to review and investigate right now. We hope down the road to be able to actually pull those codes for vertebral compression fractures, et cetera, and they would be coming in then through a referral process.
I can address the education materials. We did create our own education materials here at Wake. There's a lot of non-proprietary educational materials on the National Osteoporosis Foundation website and the National Bone Health Alliance website that are free, accessible to patients. You can utilize those. We took some of that information, of course, with permission. We actually created our own educational materials. We developed a video here at Wake Forest that is actually available for purchase if anyone is interested, and it basically is the inpatient and outpatient video that we use to show patients to introduce the FLS program. There is a new slide that was just a new slide deck, actually not slide, but a patient video educational slide about osteoporosis that was just created for through the National Bone Health Alliance and National Osteoporosis Foundation, which is also available as a link. But there are multiple resources out there, so you don't really have to reinvent the wheel. You just kind of have to think about your patient population and what kind of information that they would need and what is their best learning mechanism. So if it's handouts or videos or whatever, that is something that you can think about. But we developed our own education materials using a lot of a variety of resources. Karen, did you guys do anything like that?
We used a lot of the information, as you said, from the NOF and also from the International Osteoporosis Foundation website. We used a lot of that material.
Okay. I don't do any group visits for osteoporosis. Technically, there is a way. If it's a nurse billing for a group visit, you could do a billing visit for that. I would talk to your billing and coding people about that. If you're talking about a group visit to just do education about osteoporosis for screening, that would be one thing. If you're talking about doing group visits because you're talking about treatment for individual patients, that would be a little bit more challenging. But I currently do not do group visits unless it's like a community educational situation where I'm meeting like with the Silver Sneakers, or I'm doing some educational meetings for a women's club or something like that related to osteoporosis. Karen, do you want to address the research question?
Yes, I was just looking at that. Right now, the only study that we would consider recruiting someone for if they were interested, and this would actually have to occur while they're inpatient, is looking for men and women that have had atypical femoral fractures following bisphosphonate use. So there really isn't a blinding in that particular study. Everyone would be placed on an active medication. The only thing that is randomized in that particular study would be whether or not they start the medication up front or delayed. So that would be the only one I would feel comfortable recruiting for. Others where their medications might be blinded, at this point I would not feel comfortable wearing both those hats.
Yeah. David, do you want to address the question about the return of investment and then the hospital generating money, or do you want to address that question?
Yeah, definitely. Here.
Yeah.
Yeah, so I guess a couple things. So we do have an upcoming webinar I guess it's not November yet, next month, specifically regarding the business case that Andrea Singer is going to do from Georgetown. We also are working on a return on investment calculator that will essentially, once it's done, and we're shooting for the end of the year, early next year to have this done, will allow sites to plug in their historical number of fractures and see not only the additional costs in terms of the FLS coordinator, meds, screening, but then also show that downstream revenue that is generated, and looking at both kind of the current calendar year and then looking in the future a few years as healthcare reform continues to kick in and as folks start getting penalized financially if, say, you have a patient come in for an initial fracture, you don't do the workup, screening, diagnosis the first go-around, and 2 years later that person comes back for another fracture, that there's going to be some financial penalties that will kick in as it relates to that. So yeah, that's some of the things that we're working on. We know that the business case and the financial piece is still one of the big real limiting factors of why we don't have many more FLS programs in the U.S. and abroad.
One of the things that I do want to mention, there was a seminar done last June. It was the National Bone Health Alliance QCDR presentation, and it talked about the value-based care, how those payments are going to look, and about penalties that will be assessed if we don't meet our values, and if we don't meet those quality reporting initiatives. I think that's a great webinar for everybody to take a look at, especially if you're interested in trying to promote this through your system. Several of the questions have talked about financial advantage, and what I want you to do is sort of change your perspective and think like this. We're moving away from fee-for-service, and right now the talk is how much money can we make if we bring these patients in? Well, we need to kind of look away from that thought process, and we need to think how much money can we save if we reduce the risk of future fractures, because that's how we're going to be paid going forward. So if you can calculate how many patients maybe in the last 6 months that were 50 and over that had a fragility fracture that should have been seen, that are at high risk for another fracture, and what that would cost if they don't get seen and treated versus what you would make, that's actually the better figure that you need to be considering, because when we move forward, it's all about that value-based care, and if we want to not be penalized and we want to improve our payment contracts, then we want to improve the value by having the FLS program in place, by reducing those risk of future fractures. So I think that seminar would be a really good one. I think it was June 14th or something last year, that if anybody's interested, it's all about the NBHA QCDR and then the penalties and those things that will be assessed, and there's a slide deck that goes with it, and it's really a good, informative slide deck for you. There's several questions.
And I'll just
add
one more thing. So we are about to launch the QCDR for 2015, and obviously that does cover ICD-9 as well as ICD-10 codes. Those are all put in, and also covers meaningful use. And we're going to be doing a webinar on that in November, probably in the next couple of weeks. But in the meantime, I'm more than happy to answer any questions regarding the QCDR.
I think there is one other question on there about the possibility to register and report limited data for 2015 to NBHA QCDR. Can you submit both with the codes? Can you address that question?
Yeah, definitely. So there is the ability to use both codes for 2015, since obviously both were in place. And then in terms of limited data, yes, I think the big key would be looking at how many of the measures you're able to report on and the percentages on that. But you do not need to complete all the reporting to still get some credit for reporting in for PCRF. And there's a sheet up on our site that has some details around that.
Okay, we're running out of time, but I do want to address, there's a question here, if a PA in a multi-physician orthopedic surgeon clinic is the FLS coordinator, the first patient visit should be with the ortho MD. No, not if it's for the FLS visit. So if a patient comes in and they are there for post-fracture care and they see the orthopedist for their post-fracture care and they're in the global, say they had surgery, or even if they didn't have surgery, but if they had surgery, they need to see, then they're seeing the surgeon, they can see the PA for their FLS care. And you're not seeing the patient for the fracture, you're seeing them for their osteoporosis. Now, the new ICD-10 codes, if that orthopedic surgeon used pathological fracture with osteoporosis, then you can use that code, but that's not going to be your primary code. Your primary code is going to be the osteoporosis code, and you can bill for that on the same day, even if the patient's in the global. If there's further questions about that, I'm happy to talk one-on-one with anybody who may be interested related to that, related to billing and how you do it in orthopedics and how that all crosses over. I'm not going to be able to get to all that on this webinar, but happy to talk with someone one-on-one if they are interested in doing that. Also, there's other questions about treatment. I think both Karen and I both could address our treatment protocols. I'm happy to address what we normally do in orthopedics post-fracture and how we manage what we do with the different medications that are available and how we educate the patients on the anti-resorptives versus the anabolic agent and those kind of things. And those questions may best be answered on a one-to-one conversation. So happy to address those as well. The last question was, can someone other than a mid-level provider be the coordinator? Well, the question is if the coordinator can be the person who identifies the patient and gets the information to the provider, but if you're not a mid-level provider or you're not a physician, then you don't have an NPI number, so you can't bill for the visit. And I think that's the number one issue is we want to be able to maximize reimbursement. So if we can bill for that visit and improve the value, that's what we want to be able to do. So coordinator doesn't always have to be the clinician. It may be a coordinator and then there is another clinician. But, if the coordinator and the clinician are a mid-level or a physician, and we usually call ourselves advanced practice providers, but if there's an APP or a physician, then they can bill for the visit versus someone like an RN who doesn't have an NPI number, then they would just be mainly the coordinator of identifying and getting the patients in for their appointments. And I think we're running out of time. I'm going to turn it back over. I don't know if anybody wants to answer any other questions real quickly. So here we go.
Great. Well, thank you, Anne and Karen, and thank you all for joining us today. I just wanted to make sure that all of you do visit Fracture Prevention Central for the resources and tools that were discussed, not only materials that you can use for your own needs. We actually do have a whole host of materials from Kaiser that are in multiple languages that I think would be incredibly valuable. We also do have information on the business case, and as David Lee mentioned, we will be having an upcoming webinar on November 18th with that information. And then lastly, NBHA's FLS 101 consult service, where you can submit your questions and we will connect you with an FLS expert. So before we end the webinar, I just also wanted to ask that you please take a moment to fill out the evaluation form about the webinar, and do not hesitate to contact us at NBHA if we can be of any service. Thank you, and have a great rest of your Thursday.